Welcome back to my channel, and in this video we are continuing our exploration about the ankle joint biomechanics, that too in particular talocural joint. Through this video we are going to find answers to the questions like what type of injury, whether it is dorsiflexion or plantar flexion injury, more common in ankle joint, why arthritis, that is post-traumatic arthritis, more common and degenerative arthritis less common in ankle joint. What is the role of fibula in the ankle joint biomechanics, that to talocural joint biomechanics? Why do we have decreased dorsiflexion or limitation to dorsiflexion after a distal tibiofibular joint fracture and immobilization? And finally, which are the muscles that play a role in aiding the motions in the the ankle joint, and limiting the motions in the ankle joint? To find the answers to this question, stay tuned to the video. And this is Tony's tutorial discussing the talocural joint biomechanics part 2. Yes, this is the first video after we hit the mark of 1000 subscribers. In fact, the earlier video was recorded earlier. I'm extremely thankful and express my sincere thanks to all the viewers and subscribers, because it's just your support and unconditional love that I could experience throughout this time. And I have a request that if you have any suggestions, like to include more topics or discuss in a variety manner or have some variations in our channels, definitely please let me know in the comment section or through my Instagram or Facebook profile. I will be most happy to read your comments and get your supports throughout the journey. And I kindly seek your support in the upcoming days also, until we make this channel a much more success and reach a large number of students and professionals in our field, right? Yes, let us discuss about the talocural joint. In our earlier discussion, last video was a very extensive video, and we found out answers to many questions. We found out what is the angle, what is the axis of the ankle joint. We saw that it is an oblique axis from the tibial malleoli passing through the body of the talus and passing just above the fibular malleoli or through the fibular malleoli, right? We found out that tibia is distal. We found out that it is posteriorly oriented too. And then we found out the very interesting fact that it is a dorsiflexion and plantar flexion, which are the movements in the ankle joint or talocural joint, but we saw that it is a multiplanar movement. The dorsiflexion is converted by or coupled with what you have, the abduction and eversion, whereas your plantar flexion is coupled by inversion and adduction. And the range of motion, finally we arrived at a conclusion about the range of motion, that is dorsiflexion 20, plantar flexion 50 degree, whereas abduction and adduction is about 7 degree to 10 degree, whereas your inversion eversion is less than 5 degree or 5 degree. And thus we saw that the functionally significant motion or a most significant motion is a dorsiflexion plantar flexion, because other ones are negligible, but it is always a triplanar motion or multiplanar motion or a type of coupled movement that is happening in your ankle joint, right? Now let us take forward our discussion and answer the first question: what type of injuries are more common, or when is injuries more common in the ankle joint, whether it is in dorsiflexion or plantar flexion? We have, the ankle joint has some peculiarities. Always for peculiarities, something should be responsible. And here the responsible culprit or the responsible person is your talus. And what do you know about the talus? You know that the body of the talus is the one that is articulating in this joint. We don't have to look about the head of the talus. Right, when we look at the body of the talus, we see that in our first discussion we saw that the body of the talus is slightly wider anteriorly. This is the anterior location, this is the posterior one. The body of the talus is slightly wider or larger anteriorly than the posterior one. You can see from this diagram, or you can take for example, you can take the example of our fist. Here you can see that this is a narrow portion. You can imagine this as the posterior portion of your talus, whereas this is the anterior portion. And you can see that here you have an increased diameter or increased width. So this will be the shape in which your talus will be located in our ankle joint. Now, what is the significance of that, or what can it lead to? Okay, now imagine the situation in which this is our tibia and fibula. Okay, This is our talus, or just this way we'll do it. This is our talus, anterior, posterior, and of course we have tibia and fibula. This is fibula, this is tibia. You can see that normally this one is a mortise. Our ankle joint is a mortise, but it's not a fixed mortise, and it's a mobile mortise, but mobility is restricted. It cannot expand much. It can expand, but it cannot expand beyond a limits, because you have the ligaments and other associated structures that are maintaining the stability. Now what happens in ankle joint motion? For example, we are taking consideration of a weight bearing. If this is the floor, weight bearing tibiofibular joint motion, that is your ankle joint motion, that is your dorsiflexion, plantar flexion. So weight bearing position, talus won't move, your tibia has to move tibia has to move anteriorly and posteriorly. Now let us see how is it being done in this weight bearing condition. Your tibia is moving. For example, I'm avoiding the fibula, and in weight bearing condition, dorsiflexion means your tibia moves anteriorly. That means this angle between your dorsum of the foot and the tibia decreases, or the leg decreases. That is a dorsiflexion. Whereas in plantar flexion in weight bearing, your tibia moves posteriorly. That means your angle increases and you do have plantar flexion. The situation is same when if you are sitting in your chair, you just forwardly lean. Okay, just forwardly lean or go for a squatting. You're having a dorsiflexion in your ankle. That is because the tibia is moving anteriorly, right? Whereas in plantar flexion, you can have weight bearing plantar flexion where your tibia moves posteriorly. So in this situation, in the weight bearing situation, your tibia is moving. Now let us see what is happening here. Okay, weight bearing condition. Remember, it's a weight bearing discussion. Okay. Now here we have a biomechanics that this part is a concave one, this is a convex one. The body of the talus is relatively convex, so concave moving on the convex. So you don't have to worry about the convex concave rule or inverse rule, because this is a concave moving on the convex. So when your tibia is moving anteriorly for dorsiflexion, I told you tibia is moving anteriorly for dorsiflexion. What is happening in this joint? From this neutral position, relative at here, your tibia has to move anteriorly like this. Tibia has to rotate or roll anteriorly like this, slide anteriorly like this. What is happening? You have a mortise. This mortise is having 10 centimeter length. Here it is 9 centimeter, but here it is 10.5 or 11 centimeter. Now from here, when it is moving to here, your mortise expands. Your mortise has to expand because here it is a wider side. So your mortise expands, and at the end of the talus, when it reaches at the end of the talus or the anterior end, due to that wedge-shaped talus, this joint actually expands to its maximum. That means your mortise is fixed rigidly inside your ankle. It cannot move. There is no mobility possible. That makes this position the stable position. That makes this position the stable one, right? So the stable position or the closed back position of an ankle joint or talocural joint is the dorsiflexion, because your wedge-shaped talus is getting blocked inside your mortise. Your mortise is a fixed one, a mobile one, but mobility cannot expand further, so therefore it is fixed, right? But if you have an injury of the talus, what can happen? The fibula, what can happen? There is no rigidity to this mortise. It becomes highly mobile, so there may be instability at that region, but we are not worried about that. Let us focus on to what is our conclusion at this stage. The conclusion is that in ankle joint, the dorsiflexion is the closed back position or the stable position. Closed back or stable position. That is the dorsiflexion. Now what about the plantar flexion? This will be inversely correct, right? Inverse relationship. So you don't have to worry about that, but let us try to understand that. Here this region is narrow. I told you this is a 9 centimeter or a 8 centimeter, but here it is 8, but here it is 6. So what happens when your mortise moves posteriorly over here? When your mortise moves posteriorly over here, it becomes unstable because this is 8, but here it is only 6 centimeters. So it is having increased mobility or less stability at that time. The stability to the mortise is achieved when the mortise is expanded or the joints are maximum separate as much as it is possible. When they are in a relatively loose position like this, and they can move each other, the stability is less. Therefore, in plantar flexion, your ankle joint or talocural joint is less stable. So this is less stable at this position, right? So you can find out the answer to our first question. When is the injury to the ankle joint more prone? Which position is more susceptible to injury? That will be your plantar flexion. So inversion and plantar flexion. Plantar flexion plus inversion. Inversion is always coupled by plantar flexion. We saw that, right? Is the most susceptible position for ankle joint for injuries. So injuries are most common in plantar flexion in weight bearing. Right? Means in weight bearing is the most weight bearing is the predominant time in our gait and all our day-to-day activities. Right? Non-weight bearing we are not much focused on. No, we are not going to much focus on. So this is the conclusion. In the ankle joint, your plantar flexion is a less stable position, and there is always a greater chances of injury in plantar flexion plus inversion position. The ligament injury, sprain on the ankle joints are very common, and that is why we often say that the foot just got turned over when you are just getting out from the bed, or when you are descending a staircase, and that is due to inversion coupled with the plantar flexion, where your mortise is relatively less stable. So we talked about the first question. We found out the answer for the first question. Which type of injury, or which is the position most common for ankle joint to be injured? The second question that we have is a straight-head answer, the osteoarthritis. What type of osteoarthritis is seen? We don't have much about the degenerative normal type of arthritis that we have in the knee joint, but of course we have osteoarthritis, that is a post-traumatic arthritis, very common in the ankle joint. The reason is that your ankle joint has a hyaline cartilage. Okay, sorry, your ankle joint has cartilage which is very capable of sustaining injury. That is your talocrural joint has a hyaline cartilage which is very capable of sustaining a great deal of injury. So that peculiarities. At the same time, not like your knee joint. Knee joint, the weight has to be transmitted through your medial and lateral contact, but ankle has a diverse mechanism. The weight is transmitted through all the structures that is seen. The weight is transmitted through the plantar arches. You have strut mechanism and various other techniques in the ankle joint adapted to reduce or dissipate the weight bearing forces. So weight bearing forces are much easily dissipated over the ankle joint. So normal degenerative arthritis is very less common, but of course post-traumatic arthritis is very common because you have a fragile structures, or you have your ligaments and other structures much more exposed, and more greater is the chance of injury, especially when you have a plantar flexion and inversion combined. Also the triplanar motion, the complication due to that, and various other factors like the greater role of weight bearing, and the role like it has to alter its shape according to the contour of the object, and various other functions served by the ankle joint makes it a greater chance of post-traumatic arthritis. That is due to some injuries. So there can be injury and we go for immobilization, we don't go for proper rehabilitative protocol. Ultimately it can lead to osteoarthritis, and sometimes ankle sprain and ankle strain, etc. We often try to neglect it by taking some traditional medicines, or what you call some ointments and so on. If you do not properly rehabilitate your ligaments and ligament injury and sprains, etc. in your ankle joint, there is a greater chances of injury. So if you suspect any cases of injuries, better go for a specialized, either a physiotherapist or a doctor, and get to know what can be done for the better rehabilitation, because these structures are very crucial in the stability of the ankle joint, right? So the post-traumatic arthritis is most common in the ankle joint, post-traumatic arthritis. Our third question is what is the role of fibula? We know that fibula do not have much role in the weight bearing, especially there is not much role in the weight bearing, because much of the weight is transmitted through your, which joint itself? Your tibia itself, right? Especially except in eversion, the fibula has very less role in weight bearing. But I told you in the first video that if you have any doubts on this, just refer back to the previous video. I will give you the links. We saw that the fibula has a very efficient role in the function. That is, the function of the mortise or the mobility of the mortise is a function of the tibiofibular joint and especially a fibula. The fibular motions are the one that regulates the function of the mortise. Let us see how it is done. Okay, now we have the angle joint over here, right? We have all the bones over here, and let me just draw it like this. You have an angle joint like this. Okay, just a rough figure. And now, what is the peculiarity that we saw? We saw that the lateral facet of the tibia, okay, that is this facet of the tibia, is the fibula is larger than the facet in the tibia. The facet in the tibia is a very small one, and this is a larger facet. And correspondingly, the facet for fibula on the talus is also larger than the facet on the talus for the tibia. Right, now what happens is that here the facet is a greater one, okay, here the facet is a large one, right? Let us see that. Here the lateral facet is a large one. Here it is a smaller one, okay, here it is a smaller one, here it is a smaller one. So you can guess the shape of the joint like as a cone, okay? We can convert it into a cone shape. You can see that this is the base of the cone. This is the base of the cone. This is the apex of the cone. Apex of the cone is at the medial malleoli. Base is at the lateral malleoli. Now, what is the peculiarity? Can you imagine what happens when dorsiflexion and plantar flexion is happening? What happens when dorsiflexion and plantar flexion happens? The tibia can only move this small range, right? Whereas the fibula has a diverse range to move because of its larger articular surface. Correlate with the knee joint, where we studied locking and unlocking. What is the main reason for locking and unlocking? That is because of the size difference between medial malleoli and the medial femoral condyle and lateral femoral condyle and tibial condyles. The lateral condyles is smaller. Okay, so that is what actually happens, similar to here, but there it happens to be a locking mechanism. But we are not focusing on the locking mechanism here, but here. So the tibia is this much only, very small narrow surface. So this malleoli this range of motion which is happening in the dorsiflexion, plantar flexion is only possible in this small degree. Whereas in fibula, it has to cover a greater role. It has to cover a greater role. That means your mobility at the fibula is very crucial for the functioning of angle joint. The mobility at the fibula, can fibula move alone? No, it is linked to tibiofibular joint, superior and inferior tibiofibular joint. So when mobility of the fibula is an essential component, the mobility of the superior and inferior tibiofibular joint or proximal and distal tibiofibular joint is also very important. That too, the distal tibiofibular joint. So if there is a problem with the mobility of the fibula, what can happen? The total function in your angle joint can be disrupted. And this is the answer for our question, like why a distal tibiofibular joint fracture can result in decreased dorsiflexion. We saw that during dorsiflexion, this wedge shape has to move. For this, what is expanding? Your tibia is relatively fixed. The expansion is done by your fibula. What happens in distal tibiofibular fracture? We go for open reduction, internal fixation. And what happens in that? After a period of immobilization, you try to rehabilitate the patient, but we have a very less range of motion available. That is because you might have a tightness or restricted range of motion possible at the tibiofibular joint, that too at the distal tibiofibular joint. So this distal tibiofibular joint has a very crucial role in providing the mobility at the angle joint, because fibula is related to the mobility at the angle joint mortise. So when mobility at the angle joint mortise is decreased, one of the reasons might be your problem with the fibular mobility. So correlate with that, okay? And proper and early rehabilitation is one of the most important tool that can accelerate or help us in achieving greater amount of dorsiflexion. So to summarize, we can say that dorsiflexion and plantar flexion at the tibiofibular joint, so the angle joint is a function of the mobility of the fibula. So fibula has a very crucial function, and this diagram, which is representing fibula as a cone-shaped, a truncated cone, you can say that this is the medial malleoli, this is the lateral malleoli of the fibula. That means here the range of motion is possible, a greater range of motion is achieved, here a very less range of motion is achieved. Okay, so that means your tibiofibular joint or a talocural joint function is highly dependent on your tibia. Alright, yes. So we got answers for 3 questions, And finally, let us see what are the role of the muscles around the ankle joint and ligaments around the ankle joint in preventing or aiding the motion possible in the ankle joint. Yes, now we are going to look into the muscles and other structures which can provide muscles and other structures which can have a role in the stability or mobility at the ankle joint. Okay, we have motions like we have dorsiflexion, and you know the muscles of dorsiflexion, which are the muscles tibialis, anterior extensor hallucis, longus extensor digitorum longus, and the lateral compartment muscles. So they are responsible for dorsiflexion. We are not talking about the muscles which are responsible for dorsiflexion, but the muscles which can limit the dorsiflexion. Which are the muscles that can limit the dorsiflexion? Of course, your posterior muscles, which includes your gastrocnemius and soleus. So this muscles has a capability or role in limiting the available dorsiflexion. So the tightness of these muscles or passive tension, increased passive tension in this muscle can decrease your dorsiflexion range of motion available. And that is one of the reasons by which in extension, when the knee is extended, you have a less amount of dorsiflexion. Why? Whereas when knee is flexed, you have a greater amount of dorsiflexion capable. If you have any doubt, just check on to that. Just stand straight and just try the dorsiflexion, it's limited. Whereas when you go for knee flexion and you try for the dorsiflexion, it's relatively easy. Why? That's the reason is the gastrocnemius muscle, whereas its origin is from the femoral condyles. So when knee is extended, the muscle is stretched out and there is insufficiency in the muscles. Whereas when knee is flexed, it's relatively free. That muscle is relatively having a greater length and it can provide a greater amount of dorsiflexion, right? Whereas what are the structures which can limit the plantar flexion? Plantar flexion is of course provided by the calf muscle group, and thus the tightness in or the restriction that happens in the anterior group, that is your tibialis anterior, extensor hallucis longus, extensor digitorum longus, can restrict your your plantar flexion. This is just an opposite action. For example, when you have dorsiflexion here, your tibialis group and the lateral compartment does this dorsiflexion, whereas this compartment restricts that one, okay, restricts or limits that motion. Right? Whereas the same, when you go for plantar flexion, this is the ones that are producing the motion, whereas this is the one that is restricting the motion. This is a quite common known to us, right? And now we have the ligaments like the medial and lateral collateral ligaments and various other ligaments in the ankle joint, like the deltoid ligament, etc. This ligament has a very significant role in the stability of the ankle joint, and that is why you have some ligament injury, you feel that your ankle is giving off and you have greater difficulty in doing your functional activities. The reason is that the ligaments are producing or functioning to provide or prevent the side-to-side movement. I told you that when dorsiflexion and plantar flexion is happening, there is a slight bit of abduction and eversion and inversion, various triplanar movements happening. So to provide a restriction to that and to prevent further side-to-side movements of the ankle joint, your ligaments are working. So even though one of the ligament which is, for example, lateral collateral ligament is injured or strained, not just that abduction movement or adduction movement is limited, but the dorsiflexion itself, because in dorsiflexion of itself you have the coupled motions. So this stability or injury to these ligaments can have various greater complications than in other joints. In other joints it might be injured or it might be strained only when it might produce a problem only when the concerned movement is being done or the opposite movement. But here any movement, these ligaments can have a greater role. So ligament injuries which are very important in reducing the function at the ankle joint. And finally, we see that the muscles, for example, your tibialis posterior and the flexor group of muscles provides which sort of stability? Your medial side of the ankle is stabilized by your tibialis posterior, flexor digitorum longus, flexor hallucis longus. Whereas your other side of the muscle, that is the lateral side of the muscle, that is peroneus longus and brevis, provides stability to the lateral aspect. What I am telling is that the ankle joint, due to its complex biomechanics, of course one of the most complex biomechanics in the body is sometimes in the ankle joint. It is very interesting to study. At the same time, when the biomechanics and function is complicated, you need a greater role of a stability achieved by various muscle group. In fact, this discussion about the muscle is not complete We cannot discuss the muscles of an ankle joint or talocural joint alone. We need to discuss about the other joints and finally come at the conclusion, because we are having a simultaneous or a complete set of movements in the ankle joint rather than individual joints. For understanding, we are picking up individual joints and learning, but at the same time we should understand the function by discussing the ankle joint as a total, which we will do at the end of this session. And in the next video, you have an important topic which many of you are waiting, that is to understand the subtalar joint, the various movements, pronation, supination, the coupled movements that are happening in the subtalar joint. We'll do it in the most easiest manner. Right? And don't forget to subscribe to our channel, and if you like the video, kindly click the like button. And once again, I thank you all for your support, and please let me know through the comment section or through my Facebook or Instagram profile. Don't forget to follow that. Any suggestions regarding this channel and your future ideas or suggestions for the improvement of channel, of course the mutual improvement of each and every one of us. Thank you again for your support, and this is Tony's tutorial.